Our worry is if you don't have a connective tissue attachment, you're going to have epithelium come all the way down to the notches you make in the roots. And this is from a study from Jack Caton back a long 30-some years ago. It's a monkey study where they were able to regenerate bone, but not the periodontium. So when we get to the periodontium, what we're interested in is what's happening up here. If we're going to protect this bone, we want to see the epithelium, and the epithelium stops. This is the same arrow. The epithelium stops here because the connective tissue is attached. Do you see the Sharpie fibers here? Can you see them? We're going to then look at the next box down at this level. If you have this type of attachment of the connective tissue to the object, be it tooth or implant, we have a protective system. Again, we want to stop the apical migration of this epithelium. Even if we have an ugly tooth like this, and here we can see that once again, we've stopped the epithelium, and here we have new cementum, new ligament, new bone, da-da-da. But basically, the whole name of the game is winning the epithelial race. In the 1950s, this is referred to by John Pritchard and Jerry Kramer and other people. We have to win this epithelial race. They made flaps without papillae. They did anything they could back in those days, if you look historically. And we're faced with the same thing with implants. How can we control this? So we know we have a minimal dimension of 3 millimeters. We're always going to have 1 millimeter of connective tissue, 1 millimeter of junctional epithelium, and if you don't think you have a millimeter sulcus, you're in the wrong room, whether it's an implant or a tooth. We always are going to have a sulcus when we finish. So if we translate this to our problem with an implant, we put the implant in, if we're doing 2 stages, just to set the clock back 20 years, and we put the implant in, and we're trying to maneuver where do we put the shoulder relative to the crest. I've always believed that we should put it at the crest, because if the further down you put this, where the microgap is, you're just going to lose the bone after that point. And with this product that we're looking at, I made the decision for the research to put the line between the 2 laser cuts right at the level of bone, so that I could have this available, the top 8-micron cut, available for connective tissue attachment and protect every cell of bone. Since that's the idea of it, that's what I wanted to do. Well, of course, this is what happened. If we look back in our practice, most of our older cases will demonstrate a dieback. It's stable, but wouldn't it be nice to preserve all of this bone, to preserve the papilla and not worry about this, and perhaps have less possibility of a black triangle in the anterior region? Going back to the information we have, once again, with the implant, David Cochran showed that it's about 3 millimeters. This was his findings. It's very similar to that form with the tooth. I think that the probing depth here is much less than we see in our practice. I know I was in my practice yesterday. I saw nobody with a 0.16 millimeter sulcus. In fact, I don't think at this stage of my life anybody anticipates that I could actually visualize a 0.16. Nevertheless, these are publications, and it seems to come out in this range of 3 millimeters. Erickson then went on to talk about this inflammatory infiltrate. He has one infiltrate up here from plaque, but this is the one relative to the microgap conversation and the dieback of here. And essentially, the bottom line is there's a dieback in order to make room for a millimeter of healthy connective tissue. What I think the value of this information is you don't have to die back. You get the connective tissue attachment if you place the implant properly, and you don't have to lose any of the bone, because this bone is the prime dictating factor of how the soft tissues will be and what the state of health is going to be. So, we have to be concerned with the implant abutment connection and where it is. We understand that we're going to have 1 millimeter of connective tissue, and it's just going to be a question of how we're going to get that, whether we have to die back or an implant can be designed to give this to us. If we look at where to place an implant, and we go to this study by Herman, we can see that you can place it at the crest, you can place it a little bit above the crest, or you can put it under the crest. I really do not think that there is any biologic validation with what we know today to insert an implant 1 millimeter below the crest. Because I think then you're going to start losing bone at this level and you're going to lose more. And if you're using a one-piece implant which is polished, the polished part cannot have osseointegration. And you're going to place the rough part of it down here, you're going to lose bone, you're going to lose more bone. So I think the idea is either put it at the level or a little bit above. The information I'm going to share with you, I've placed these roughly about 1 millimeter above the crest of bone, so that that millimeter would have the area where we anticipate a connective tissue attachment, where the laser is designed to do that. What do we know before this? We know we need 3 millimeters of tissue. And we know from Jan Linde's study, where he reduced it to 2, that he lost another millimeter of bone to get it to be 3 millimeters. We know the presence of the junction between the implant and the abutment can result in an inflammatory infiltrate. We know that we have to have and maintain an inflammatory-free connective tissue zone about 1 millimeter apical to the inflammatory zone. We know that that reformed from Erickson's studies. And we have 2 millimeters is the vertical distance from the platform of the bony crest and appears to explain the dieback modeling. We know from studies from NYU that depending on the closeness of the implants mesiodistally, you're liable to have more loss of bone. I'm going to show you a short film to try to explain how the cells attach.
The LaserLock Bioaffinity Collar, programmed cell response for soft and hard tissue attachment. BioLock's revolutionary computer-controlled laser ablation technique utilizes a pulsed excimer laser to form the unique repetitive geometry of its 8-micron and 12-micron horizontal cell channels in the LaserLock Bioaffinity Collar. The 8-micron cell channels of the LaserLock Bioaffinity Collar inhibit the vertical migration of epithelial cells, maintaining space for fibroblasts and osteogenic cells to attach to the implant. Epithelial cells cannot bridge the gap created by the 8-micron cell channels, thus forming a complete outer layer on the surface of the soft tissue without undermining the formation of a soft tissue seal to the implant or blocking crestal bone healing. After the epithelium firmly integrates into the first 8-micron cell channels of the LaserLock Bioaffinity Collar, fibroblasts migrate to the space on the collar below the epithelium. Fibroblasts orientate, proliferate, and attach to 8-micron cell channels. Collagen fibrils are then secreted, which cross-link with the native tissue to form a tight, soft tissue seal. Once the seal is formed, gingival margins and papillae become more stable, and the likelihood of oral inflammation and peri-implantitis decreases. Once a stable soft tissue seal is formed, osteogenic cells are allowed to form a mineralized attachment to the implant. LaserLock's 12-micron cell channels direct osteogenic cells to migrate along and produce a strong horizontally organized bone matrix within the channels, increasing resistance to loading forces. It has been observed that over time, the 12-micron cell channels can direct osteogenic cells from the higher interproximal bone to migrate toward the buccal and lingual aspects of the implant and form new bone. After initial healing takes place, crestal bone and support for aesthetic restorations is preserved.
When I saw that film, I thought, well, this is an interesting cartoon, but it's going to be awful hard to accomplish this with human histology. So let's take a look. This is called the micro-CT, and we are able to do this with a human block before we do the processing for the traditional histology. The red is bone. So here we have the bone right up to the top of the threads, virtually no bone loss, which is what we dream about at night. This is the way we'd like our cases to heal. And when we do the actual histology, we see a remarkable bone-to-implant contact. This is probably more than 80%. When a group of us accumulated human blocks back about 1988 or 89, we published this in a Dutch journal called Dental Materials. I think it was Dental Materials or something like that. We thought, and this is with Thomas Albertson and Ulf Leckholm, we thought that, wow, if we can get 65% bone implant contact, that was pretty good. But as you look at this, it's a remarkable bone implant contact. And the bone comes right up to the tip of the thread and almost. As we look at this through a series, I can see already you're not going to be able to see these two white dots here, but this dark blue is epithelium. This is just the same thing made larger. And we have these two dots here. The epithelium is coming down somewhere here, but it's hard to see where it stops. It stops, as you'll see in a minute, about up here. Here's the bone, and we're going to have about 1 millimeter. You can begin to see the laser cuts in the implant at this power. Using this artifact in the histology right at this spot, we can see that some portion of this above the bone is connective tissue without epithelium. The issue that we have here is that the bone is not flat. So if we pick a spot on the mesial where we'll be right at this line, we might be a fraction of a millimeter. This is really a fraction of a millimeter because it's about 1 millimeter from here to the epithelium. Now you can see the junctional epithelium more clearly, and it's coming down to about here. And this area is connective tissue. If we look at this with polarized light, what we can see is that the fibers are attached obliquely, not parallel. So this gave the early findings where we were excited to see this. I mean, I was excited at each stage. Just to see the micro-CT and see all the bone present was very encouraging. But now as we got to this level, but we realized that, yeah, this is true. They are attached in a perpendicular or oblique fashion, but we can't really see how they're attached. We can see that we have the old bone here, and all this is remodeled bone. Everything is going just the way you write the story. The cascade of events is working perfectly. We still can't see exactly what the attachment apparatus is. So this is an implant. This is another specimen because it had to be processed differently. And this is the end of the threads where we have bone, and what we have to do is see what's happening on this surface. So if we look at this surface, there's the micro grooves, and all this is connective tissue. Everything that's growing over this. Well, let's look at it at a bigger magnification. Here you see connective tissue fibers intertwined with the surface everywhere. These are major accumulations of connective tissue just covering everything. They're blanketing the surface. Here we can see this area. You can see all these grooves on the surface, all these balls, and the different fibers connecting in and out. Just look at what you're seeing here if you doubt that there's a physical attachment of this connective tissue to the surface. Now we're up to 12 times. Just look at these fibers growing around and strangling. They're almost like a noose that comes around and grabs these. But you have so many thousands of threads of collagen here, that the attachment really can only be thought of as secure. Of course, the higher we magnify this, the more impressive it becomes. But all we are looking for is to have 1 millimeter of attachment like this to protect the level of bone and to prohibit the epithelium from migrating. Now, an interesting observation, this is the inside of the flap. This is the inside of the gingiva. And we'll be able to look at the sulcular epithelium, the junctional epithelium. Here's the sulcular epithelium. And what you see here, as we move from right to left, you actually watch the epithelial cells desquamating at a rate we know in the human is about every 4 to 7 days. These cells are actually sloughing off into the sulcus. If we go to the junctional epithelium and you look here, you can see a neutrophil in the middle of this. There's endless numbers here that sort of serve as the vacuum cleaners to clean up the area. That when we think about all the bad things that can get into the sulcus and the epithelium. And then we get down to the connective tissue level where you can see how dense the connective tissue is as it connects. We've already seen the connection. I don't have long-term cases, but Carrie Shapoff, who's worked with this system for a long time, lent me a couple just to show you. This is an abutment, but we can see the attachment here, and it holds the bone well. This is a case of 3 implants in a periodontally compromised patient. You can see the threads end here and the bone ends here. The bone is far superior to the threads rather than dying back to the threads. And that's 2005. Looking at the same case in 2006, same thing. We don't see the dieback that we're accustomed to. There are no 20-year-old cases with this laser preparation of the collar of the implant. But I personally will not be surprised if 20 years from now someone stands at this microphone and shows that you can preserve the bone for a very long period of time. Because what has happened is that we have found a biologic substitute that we can apply to the surface, titanium surface of an implant by how we alter the collar of the implant. So, in summary, it becomes important as to what level you place the implant. And it eliminates any possibility of justifying putting the implant below the bone surface. You have to have something sticking up above it in order to have give the connective tissue a chance to, the collagen a chance to attach. And significantly, it's an opportunity to eliminate this whole microgap dieback theory that's been set upon us by what our old traditions are, and to accept a new paradigm of thought. Thank you for your attention.